Okay, so let's continue with the question number 64. It's 52-year-old patient fell with a 3-meter height and on the flat grounds with the right lumbar area. He complains of the pain in this area. So we have seen that this patient has been fallen down. Now if this patient has been fallen down on the flat grounds with the right lumbar area, he complains of pain in the area. What we have seen, the complaints of the pain in the area, and other than that what we will see, there is a microhematuria in this area. There will be the microhematuria in this area. Excretory urography revealed that kidney function is satisfactory. So we can see that if we did the excretory urography, and in excretory urography what we show that the kidney function is satisfactory. There is no involvement of the kidney. So what is the most probable diagnosis? So see, if any patient is there and we see that the person is fallen down, so there is a terminology we use like in the forensic medicine and all this, like some we have the bruise, the contusions. The contusion means when the fluids or the blood will be accumulated in the below the skin, so that we call the contusion. The bruise, like if there is some scraping will be there on the skin, we call the bruising. So there is a microhematuria in the microhematuria in the urine, and excretory urography kidney functions are normals, but we see there is a microhematuria. So it means there is a problem with the something related to problem with the kidney, and there can be the microhematuria. So little kidney, the bleeding due to kidney can be there, and we call these conditions as the contusions. Okay, we call this condition as the contusion. So contusions or the bruise, like we call the kidney contusions or the kidney bruise. So that means it will occur if following any trauma or any injury or fallen down trauma, the person's fallen down. So we will see there is a contusions type of the things. Okay, so this is the direct questions. Then after that we will be having question number 65. The question number 65, female patient has been suffering from pain in the right subcostal area. Now we have seen that there is a pain in the right subcostal area. So we know that the right subcostal area, bitter taste in the mouth, periodical bile vomiting for a month. The patient's put off 15 kg. So weight gain of to the 12 kg. Body temperature in the evening is 37.6. Sonography revealed that bile bladder was 5.5. There is a wall 0.5. Choledochus means like the bile stone, we can say 0.8 centimeter in diameter. Anterior liver segment round disc, hypoechoic formation. So our question has been solved. So in the liver segment, what you are seeing, the round is hypoechoic formation up to 5 centimeter in the diameters. All of these formations are. So if you see there is any hypoechoic formation, so we call this as the hydrated cyst. So when we discussed about the liver abscess, so in case of the liver abscess, remember we can having the three type of the liver abscess. The first, we can having the pyogenic, or it can be the second, it can be due to amoebic, or it can be due to hydrated cyst. It can be the hydrated cyst can be there. So remember that if pyogenic is there, so in the pyogenic means that is some bacterial involvement. So the pyogenic means there was a bacterial involvement will be there, and which bacteria will be there, that is the streptococcus millari bacteria. The streptococcus millari bacteria will be there, and other than that we will be having the E. coli bacteria. So pyogenic, the streptococcus millari, or we having the E. coli bacteria. After that there will be the amoebic, and amoebic liver abscess is caused by the ant amoeba histolytica. It is caused by the ant amoeba histolytica, and this is transmitted through the fecal-oral route. If we talk about the hydrated cyst, so hydrated cyst, remember that is caused by the Echinococcus granulosus. It is caused by the Echinococcus granulosus. So we have the pyogenic bacteria, the Streptococcus millari or the E. coli. Amoebic, we have the Entamoeba histolytica through the fecal-oral route. Hydrated cysts, we have the Echinococcus granulosus. So in case of the pyogenic, remember, आज मुझे ऐसा क्यों लग रहा है मैं खुद को पढ़ा रहा हूँ. I don't know, I'm not. Are you here, everyone? Anna, it's feeling that today today it's me only. I don't know why. It's same as usual. So we having the liver abscess, and the liver abscess, what we see, there is a pyogenic liver abscess, amoebic and the hydatid. Then we will be having the that the hydatid cyst. Then we see there is a Streptococcus miliary, that is pyogenic liver abscess. Amoebic, we have the Entamoeba histolytica. Through the fecal roots, Echinococcus granulosus will be, that is hydatid cyst. So in case of the pyogenic, what we will see, there is a single multiple abscess will be seen. There will be the single multiple abscess will be seen. As it is the bacterial infection, so we will see the multiple single or the multiple abscess can be seen. As we know that if it is the bacterial condition, so there can be the chills, rigor, the jaundice, there can be the chills, rigor, jaundice. Other than that, what other possibility? High grade fever, and there will be the increased risk of septicemia. There will be increased risk of septicemia. So all these are possible in case of the pyogenic bacteria. So for this we will do just the blood cultures, and we will do the pus cultures, and we will able to treat these conditions with the antibiotics like the cephalosporins or like penicillin, aminoglycosides, gentamicins. So we will do the blood culture or pus cultures we will do. Other than that, we have the amoeba, that is the Entamoeba histolytica. In the Entamoeba histolytica, remember, it is usually what we will see that the single abscess formations will be seen. Usually the single abscess formations will be seen, and in this we will see the fever. Along with that, we see there is a jaundice will be seen. And remember, they have the very unique ulcer that is known as the flask shaped ulcer. That is the flask shaped ulcers will be seen. The flask shaped ulcers will be seen where in sigmoid colon. The flask shaped ulcer will be seen in sigmoid colon. In the sigmoid colon we see, or that the flask shaped ulcers. Along with that, we will in this also what we will do, we will do the ultrasounds of abdomens to check about the liver abscess and the abdominal also. Or the best is for all those things, pyogenic, amoebics, or hydatid cyst. We do the CECT. After that, we will do the stool test. In these conditions, we will do the stool test for isolation of the cyst of the Entamoeba histolytica. After that, we will be having the hydatid cyst, and hydatid cyst again, that is the usually single. It is again usually the single cyst will be seen. Usually the single will be there, and along with that, in this also what we will see, the patients will be associated with the fever, and patients will be having the jaundice will be there. On CECT, what we will see, water lily sign. What we will see, water lily sign will be seen. The water lily sign will be seen in case of the hydatid cyst. Like this type of the pattern will be seen on the like CECT of the abdomens. Water lily, we call this as the water lily signs. So in this we can give the as it's caused by the Echinococcus, so we know that it is dog tapeworm. Echinococcus, another name is dog tapeworm. That is dog tapeworm. So we can give here the albendazoles, mebendazoles, all these type of the drugs. Along with that, what we will do, we will do the some percutaneous aspirations will be done as a treatment. We will do the percutaneous aspirations will be done. Okay, so remember that if we having the three type of the liver abscess, pyogenics, the amoebic or the hydatid cyst. In hydatid cyst, we see that is caused by the Echinococcus granulosus, the dog tapeworm, and it is usually single, and it cause fever, the jaundice, and the CECT. What we see, the water lily signs, and the treatment for this is the percutaneous aspirations. And this cyst on the ultrasounds will be looks like the hypoechoic. The cyst on the ultrasounds will be looks like the hypoechoic. Hypoechoic means hypo, like less dense will be there, the hypoechoic signs. So that will be looks like the whitish. Okay, like abscess will be there, hypoechoic, that will call the on ultrasounds. If it is the hypoechoic, that will be the blackish. that will looks blackish. So this different, because normally what we see, the normal architectures of the ultrasounds or the tissue structure, that is normally that is the gray in color, but hypoechoic means it will be looks more blackish colors. So if you see there is a roundish hypoechoic formations, that means you will see, and or in the liver segments, so they definitely they are talking about the hydrated cyst. Okay, so that's why we will be having this is the alveolar echinococosis of the liver. After that, these questions mostly like we did about the breast cancer, but breast cancers, there is a one more thing in the breast cancers. There is a terminology we call the peau d'orange, peau d'orange, and the peau d'orange, it simply means like the orange peel. Its name is orange peel. Orange peel, the name of the that peau d'orange, the like meaning of this terminology is the orange peel. So the orange peel appearance, the breast will be looks like the orange peel, or here in this question we see that the lemon peel. So lemon means again the orange, so the orange peel or the lemon peel appearance if we see in case of the breast, we call this condition as the peau d'orange. We call this condition as the peau d'orange. What we will see in this type of these conditions, we see there is a like the dimpled, this is the like the dimpled conditions of skin of breast. The breast skins will be having some dimples will be there, and that will resembles the onion peel, that resembles the onion peels. And due to like if we indicate the peau d'orange, this is the skin that is presents that is dimpled area, it will becomes the thick, it will become the thick area, and we will see there is a redness, we will see there is a redness will be there. Along with that, there with the tenderness of the skin will become the hard, the redness and the tenderness of the skins will be seen. Along with that, this like the breast will be filtered with the some hydropic changes will be seen in the breast, and can presented with this some abscess formations, So we have seen that if you see the lemon peel appearance or the orange peel appearance, so remember that is talking about the peau d'orange. And the peau d'orange, this is like the we can say that the type of the breast cancers, because in the type of the in the breast cancers we discussed that if the dimple condition is there or the bloody discharge is there, so we categorize that into the blood cancers. So if you have seen the lemon peels, and the dense consistency means the hard will be there, and along with that we see there is a hyperemia, all these type hydropic changes will be seen, and hardened enlarged mammary gland, the hyperemia, the redness of the or the skin will be become thick. So that is what that the hydropic or the infiltrative, that is the cancer of the mammary glands, and that is which cancer, that the peau d'orange cancer. Okay. After that, question number 67. The question number 67, we will be having the cholecystectomy, and the cholecystectomy 6 years ago because of the chronic calculus cholecystitis lately has been suffering from pain in the right subcostals. Now you can see that there lately it has been suffering from pain in the right subcostal area, and we will see there is a recurrent jaundice will be seen. Now jaundice has not gone for the last 2 weeks. Stenosing papillitis. What is the stenosing papillitis? What is the papilla? We know that if we having the liver, in the liver we have the right hepatic duct, the left hepatic duct. These two hepatic ducts will open into the common hepatic duct. So we having the right hepatic duct, the left hepatic duct, and that will open into the common hepatic duct. That will open into the common hepatic ducts, and once it will open into common hepatic ducts, we know that we will be having here, that is the which duct, cystic duct of the gallbladder. Cystic duct of the gallbladder and the common hepatic duct, they will combine to form the common bile duct, and this common bile ducts will open into the duodenums. They will open into the duodenum, and this open into the duodenums through which papilla? This is through the major papilla, and we having the pancreatic duct also. Who is Ashiya Sharma? Ashiya Sharma कौन है ये? Hi, who is Ashiya Sharma? She is left. ठीक है, the duodenums and the major papilla. ठीक है, major papilla is there, that is the major papilla, so it will open into the major papilla. So remember that. And also we having the pancreatic duct. Pancreatic duct we have the minor papilla, and the pancreatic duct will open into this minor papilla, and then both they will open into the duodenum. The pancreatic duct and this common bile duct, they open into the duodenums. So if you have the stenosing papillitis means narrowing of the papilla. You see there is a narrowing of the papilla. We discussed the many times, like when did the ERCP, we do the MRCP in all these cases. So our cholecystectomy, I think we discussed before also. So in all these things, what we will do, we perform the endoscopy. So endoscopy, what we will do, we put a tubes through these papilla, and through endoscopy, what we will do, we will try to dilate this papilla, and we will try to cut these sphincters, the papillar sphincterectomy. That's why we call it the endoscopic papillosphincterectomy. And remember that there is a one more thing about these conditions, like when we talk about when we talk about this type of the conditions. So in these type of the conditions, there will be some, like if as in the question they were given, they had cholecystectomy the 6 years ago. So they have the cholecystectomy 6 years ago. So after that there are the complications, and the complications will be like there is a bile leak will be there, and after that there can be others, like the patients will be having the, due to bile leak, their patients will be lead to the recurrent jaundice, and we will see there is pain in the right subcostal area will be seen. Okay, these are the complications of the like this the chronic cholecystectomy, and the complications will be occurs after many years. Okay, after that this is the easy questions. Whenever you put the IV lines, whenever you put the IV lines, okay, so IV lines, if you put at the wrong places, or you're not able to put on the directly on the vein, so at that time what you will see, there will be direct accumulation of the fluids, there will be the accumulation of the fluid will be there, and that will lead to the phlebitis, the inflammations, that will lead to the thrombophlebitis, the inflammations of the veins. This is the most common, or the most common, like we can say the accidentals done by the, like this interns or the trainers, and that is the most commonly seen in case of the IV drug user also, or IV line when we give the IV lines. Okay, because the accumulation of not the fluids, the accumulation of the bloods, so the accumulation of blood will be there, and when the accumulation of the blood will be there, of course there will be the clot will be forms, and due to this clot they will be causing the inflammation of these veins, there will be the inflammation of the veins will be there, and we call, what we call this condition, the phlebitis, the clot plus in veins inflammations, that is thrombophlebitis. Okay, so we put the IV lines. If you put the wrong IV lines, so there will be the accumulation of the fluids, and that will lead to the thrombophlebitis. As is in this question also, there is surgery for the gastric antibiotic pre-operative infusion therapy. So this patient is given the pre-operative infusion therapy. Up to 3 liter the liquid was introduced into the right cubital veins, जो हम hand के अंदर, ठीक है, near our elbow front, that is the right cubital veins. He felt a dragging pain in the right shoulders. Objectively, on the inner surface of shoulder there is a longitudinal hyperemic zones. Of course, the inflammatory signs will be there. The edema of the skin or the tender cords. What complication occurred in this patient? Acute thrombophlebitis, and this is very common, done by everyone. If you have not done this type of the things, then definitely you are not a good doctor. है ना? It should be done by everyone. A normal चीज है. This is done by me also, the acute thrombophlebitis. But if it is the case of, like, if the he put the wrong IV lines, and like the doctors has went out from the IPD or from the operations rooms, and no one is with him, with with the patients. So at that times it can be the very dangerous complications can be possible, because it can spread to the, because then it can spread to the hand, it can spread to the other regions, to the chest regions. That's it become the dangerous or the complicatory things. Okay, so understand that is what we call this. This is the acute thrombophlebitis. After that, we will be having question number 69. A 54-year-old patient supplied with the, why I am not telling other options, because other options are not compatible, and other options they are like not similar also. If you see the questions, the direct answers will be there, so don't need to confuse anything. Whatever the options will be important, I will discuss them. A 54-year-old patient supplied with the complaints of acute pain in the shoulder joints. What we have seen, there is acute pain in the shoulder joints. 10 minutes earlier, he fell in the street. So he fell in the streets with his arms stretched. So doctor of the traumatological unit noticed, and so there is a falling history is there. The falling history, it can lead to the some dislocations or the fractures kind of the things. Acute deformation of the right shoulder joint, the impossibility of active movement in the right extremity. We have seen the impossibility of the active movement in the right extremity, and along with that acute deformation of the right shoulder joint. X-ray, what we will see, the uncoincidence of the articular surface, means the articulating surface are not coinciding with each other, they are the mismatchings. Okay, what is the most probable diagnosis? So if we talk, this is what the as we have seen, the uncoincidence of the articulating surface, and the patient is not able to have movement, active movement in the right extremity. So the most common cancer that is done in this condition, that is what, that is the clavicles. So see, if we talk about the clavicle, so in the clavicle, this is the most common side, this is the most common bone that is fractured, most common bone fractured, the most common fractured bone overall. It is overall also, in children also. So this is what, this is the most common. Then if we talk about the most common site of fracture, that is the again the important questions, the most common site of fractures in clavicles. So remember that that will be the medial, the junction of the medial 2/3, junction of the medial 2/3 and lateral 1/3, junction of the medial 2/3 and the lateral 1/3. Like if this is my clavicles, so we will be having, this is the medial, this is the medially, so medially 2/3 and the lateral 1/3. This is the lateral 1/3 and this is medial 2/3. This is medial 2/3. So that is the junction of the medial 2/3 and the lateral 1/3. That is what, this is the clavicles, the most common site of the fractures in the clavicle. Okay, that is the important. If this is not in the options, that you will get in the options the junction of medial 3.5, junction of medial 3.5 and lateral 2.5. So the one thing you need to remember, the medial side is more, the medial side will be more and the lateral side will be less. Okay, if this is not in the option, this will be in the option. If this will not be in the option, this will be in the options. So choose according to that. If both will be in the options, then better mark this junction of the medial 2/3 and lateral 1/3. Okay, and for if both in the options, mark this one, okay, this one. If both are in the option, the junction of the medial 3/5 and the lateral 2/5, and that will be the answer. But these questions will not, they will ask you, I think, in the croak 2, very less chances, but for further exams you can get this question. Then remember that if we talk about the most common complications, the most common complications that is we see in these conditions, that is the malunion, will be theirs. Then if we talk about the treatment, so in we can give the arm slings can be given, and we can give some pressures. So that's why we will be able to treat the clavicle fractures. Then remember that is we have seen this question, impossibility of active movement in the right extremity. Uncoincidence means that is what we having, that is the malunions. The misunion or the malunion will be there. The malunion will be there. So malunion of articulating surface, this is the most common complication of which fracture, or the which fracture, that is the clavicles, or we can say this is the dislocation of the clavicles. They are mostly the same word, the dislocation of the clavicles, the dislocation of the or the fracture of the clavicles. Okay, dislocations means they are dislocated from their own positions. Like if this fractures will be there, so they can be dislocated like this. They can be dislocated like this. So what we need to do, we need to put them together, and after that we will put the arm slings, or we will give some bandage type of the things, so that it will be easily treated. Bone has the property to regenerate or to join by themselves, so that will help them. Okay, so that's why the answer will be the dislocation of the clavicles. After that, there is a question number 70. A 62-year-old patient has been delivered to the surgical department with a complaint of the sudden pain in the umbilical region. So what we have seen, the sudden pain in the umbilical regions, that is radiating to the back and groin area. That radiating to the back and the groin area, accompanied by the syncope. Syncope, it is like the same like we have saw. Like what is the difference between the? Can anyone tell me what is the difference between the syncope and the scope shock? The syncope and shock. What is the difference between syncope and the shock? Syncope will be hypoxia. Okay, so that is the things, yeah, the correct one. But syncope, yes, that syncope, what you will see, there is a loss of consciousness. So it is the same things like we have discussed in the shock. For here we can assume it as the shock, but there is a difference between the syncope and the shock. Syncope, remember, that will be the persons will be undergoing the loss of consciousness. Now the patient is in the grave condition, umbilical region is tender on palpations, the bowel sounds are diminished, AP drop is present. So we can see the blood pressure is down, so person is going into the shock. Free fluid in the abdomen, the thickening of the wall of the abdominal aorta. The most likely diagnosis is, if you see, there is something like the sudden pain in the umbilical regions, and you see the pain is radiating to the back and groin. And see here, now you the most likely for these type of the questions, always to the most likely diagnosis, rupture of abdominal, acute pancreatitis, stomach ulcer perforation, peritonitis, or acute appendicitis. Stomach ulcer perforations, we already discussed that in this type of the findings we do not get. Peritonitis, they will give you something, the Bloomberg signs, the cytokine signs, tenderness in the peritoneum regions, but again that is not given. Acute pancreatitis, we discussed that the person is bending forward, the pain will be relieved. So that type of the findings will get in the questions. Appendicitis, we will see there is a migratory pain will be seen in the acute appendicitis. We will see there is a migratory pain, so the pain will be on the epiphysis, and then it will go to the left lumbar pains, and there is a no pain in the umbilical regions in acute appendicitis. So again the questions remaining the same, and we see there is a sudden we discussed in case of the ectopic. Sudden we discussed in the ectopic pregnancy, ruptured ectopic pregnancy. Here is again, if you getting the sudden is sometime, many times what we will see, the sudden will be there whenever we will see there will be some already problem is there, and that become the jwalamukhi, that becomes that blast. So that at that time what we will be having, the sudden pain, sudden scream will be there. So that's why remember these type of questions you will see like this. Okay, before the questions, I gave you the questions today, one questions I send you in the group. So eight of you answered these questions, and many of you did not answer these questions. But tell me that, see, if you see that these type of the questions, we already studied these type of questions, but whenever you will see these type of the questions in the main exams, whenever you will see these type of the questions in main exam, so you will see, अरे यार मैंने ये तो मैंने पढ़ा ही नहीं, I did not study this type of the questions, but that questions you already did in your time. So this question sometimes what you will say, the शब्दों का खेल, what you will say, शब्दों का खेल. Remember this line. In Crofto questions you will see the शब्दों का खेल. Why the शब्दों का खेल? And this is the, like, the words play will be there. Okay, the words play will be there. The play, like, words will be arranged in the different formats, and that will make you confused. So the one thing about this, that because they're translating the paper, most of the questions can be the translating, so that's why they don't have the good English sentence, or they don't have good English grammars, so they will arrange the questions like that. So that can be the little problem for you. So the questions, so whenever you will be in the exam hall, or whenever you are practicing the questions, make sure that your mind is open. Believe in yourself that you studied everything. You believe in yourself that you studied everything. Whatever the topic is, the new topics, definitely you studied till now. If I will say that इतना तुमने कर लिया है कि definitely अगर कुछ नया भी question आ गया, so you will be able to do that. But for that you need to be concentrate, and you need to be open your mind. If you will be negative on yourself, then definitely you will make the wrong options. But if your mind will be open, if the questions will be the hard questions, will be the framed differently, definitely you will be able to solve the each and every questions. So that's why this question was not a single percent hard. It is completely easy questions. Completely easy questions. In this question, that directly ask you the infant mortality and what are the taken for the unit of observation of infant mortality. So you have seen that, you see the options. Now you see the options. You see the questions. Now you don't understand anything. Now if you see the questions, baby died at the age of 1 month, 12 month, 28 month, 8 days. Something related or something correlate with these things. Infant is there. So there will be the talking, they just talking about indirectly that what is the duration of the infant. Indirectly तो यही क्वेश्चन हुआ ना कि duration, infant की duration कितना है, 28 days to 12 months. तो he will be charged under the up to 12 months. That's what the infant mortality. The infant mortality rate will also be calculated. The infant died at the, or the newborn died at the age of the 28 days to the 1 year, to the 12 months, divided by the total number of children in this age, multiply 100, that is what give the infant mortality rate. Okay, so these type of the questions, don't fear about these type of the questions. Just you need to understand they are the easy questions, and you will be able to solve these type of the questions in the exams. The main, that's why I shared this question here. You will see the loads of the type of the question here. See, मैं तो हर questions तो कराने जा नहीं सकता, है ना? Whatever the questions they will post, they know what they will share, or what you will get in the exams. The only God knows. The one thing we can do, that we can having same topics, we can having the same knowledge, and then we can perform the exams. For that you need to be more prioritize on your questions practice. जितने ज़्यादा practice करोगे, more success you will get, and more there is a chances, more probability of doing the correct questions will be more. Okay, so let's come back again. So here we will be having that is the abdominal aortic aneurysm. So let's discuss this topic in details. समझ में आया क्या कहना चाह रहा हूं मैं, या हवा में चली गई बात? Shock may be irreversible. Yep. अपने ऊपर ना विश्वास रखो, definitely you can do, because positivity is not such things that can give you the everything. Make, if you are not the positive person, if you are the negative persons, you keep overthinking the questions, you keep overthinking everything. किसी ने कुछ बोला तो overthink, किसी ने कुछ बोला, गर्लफ्रेंड टूट गई तो overthink, बॉयफ्रेंड टूट गया तो overthink, whatever the things. ठीक है, the main thing you need to be the positive, the main thing you need to be the positive, positive, positive. Because once you hold the positivity inside you, whatever the situations will be there, you already survive the war, you already survive the war. So if you survive the war, definitely you can solve any problems, any obstacles, you will be pass out. The main thing, you need to be the positives, and you need to keep working hard along with the positivity. Only the positivity not work, but along with that, if you will be the hard workings, keep doing the studying hard, and keep yourself positive in all the situations, definitely you will be successful, not today but one day. सारी कहावत जो भी हैं, all those type of the things, all those good quotes, motivational quotes, everything will be true in the end. जिन पे अब आज हंसी आती है वो सब मस्त लगेंगे बाद में कि अरे यार सच में ये तो हो गया. Okay, so let's continue the abdominal aortic aneurysms. The abdominal aortic aneurysms, what we will see, the most important risk factors we will see in this case of the abdominal aortic aneurysms. The most common risk factor is what? That is atherosclerosis. That is the atherosclerosis. That is the atherosclerosis. Then if you see that, if what is the aneurysms? Aneurysm means like if the dilatation, if any dilatation if there. So if any dilatations from the, or like any pouching is coming from the blood vessels, so we call this aneurysms. You hear that something related to the Barry aneurysms. So in the Barry aneurysms we discussed that, like in case of the circle of the Willis, we see there is a Barry aneurysm will be there. So any pouching or out pouching is there, so we categorize that into the aneurysms. There can be the true aneurysms or there can be the false aneurysm. The true aneurysm will be there when all the layers will be out, so we call that true aneurysms. If few layers are out, we call that is the false aneurysms. Okay, this abdominal aortic aneurysms, this is asymptomatic. This is the asymptomatics, and patients will comes with the abdominal pain. Patients will comes with the abdominal pain. You will see there is a pulsatile mass will be seen. Pulsatile mass, because you see there is abdominal aorta is there, and aorta is what? That is the pulsal. They have the pulse. So that's why you will see the pulsatile mass will be there. Now from this abdominal aortic aneurysms, you can see that it can be the source of the embolus. It can be the source of the embolus, and it it then transmitted, and it can lead to the gangrene type of the things. It can lead to the gangrene type of the things will be there, and there is the high chances of the rupture of this aneurysm. High chances of rupture. What are the investigations we will do? Definitely what we will do? We do the ultrasonography. We can ultrasound of the abdomens. Then if you want to choose the investigation of the choice, the investigations for the screenings, we do the ultrasound of abdomens. But if you want to choose there will the investigation of the choice. The investigation of the choice will be the CT angiography. That is the CT and investigation of the choice will be the CT angiography will be there. Okay, that you need to remember. After that, if there is a many more things in the abdominal aortic aneurysm, but that is not like according to Crook 2. But if there is a rupture of this condition, if there will be the rupture of abdominal aortic aneurysm, then it will become a serious complications. अरे ये क्यों अटक गया? Just a second. Okay. If it is further complicated, the abdominal aortic aneurysms, if it is further complicated, the complications if you see that of the abdominal aortic aneurysms, then it can lead to the first of the things that is the most common cause of the death in case of the the cardiovasculars. If the cardiovascular patient is there, that is the most common cause of the death in case of the cardiovascular patients. Then we have to know that about the rupture. So if it is a ruptured aortic aneurysms, the ruptured aortic aneurysms will be there. So in the ruptured aortic aneurysms, what we will see, this rupture specially take place in case of the left retroperitoneal area, in the left retroperitoneal area. What are the clinical features we will see in these conditions? The clinical features we will see, there will be the patients will come going under the shock, there will be the pulsatile swelling will be there, the pulsatile swelling will be there, there can be the flank pain, along with that there will be the abdomen wall will be thickened, the wall will be thickened, and there will be the sudden pain will be there, the sudden pain will be there. Okay, for all these conditions, what we can do, if the patient's vitals are, we have to check whether this patient is hemodynamically stable or if it is hemodynamically unstable. Based on that, we will do the CT angiograms, or we do the ultrasonography, or all other investigations. And for if you have the rupture, then we can use the Dacron graft here. In this condition, we use the Dacron graft. The Dacron graft will be used in these conditions. Okay. What other conditions we will see? There will be the, other than that, if you have the soap, as if this abdominal aortic aneurysms, usually this is like if we talk about the abdominal aortic aneurysm, this is usually asymptomatic conditions, but we can see there is a hoarseness, voice hoarseness. Why the hoarseness will be there? The hoarseness will be produced due to pressing of the left recurrent laryngeal nerves. There will be the pressing of the left recurrent laryngeal nerves. So if there is mainly it is occur in case of the descending thoracic aneurysms, but it can also be seen in case of the aortic aneurysms. So what happens whenever this aneurysm will be there, it will press in the left recurrent laryngeal nerves, and the left recurrent laryngeal nerves, it have the long pathway. Left recurrent laryngeal path, it have the long pathway, and then it will go back. So that's why it is cause the hoarseness whenever this nerve will be compressed. So with this will lead to the hoarseness, and we call this condition also the Ortner syndromes. Okay, don't write that, but just remember the hoarseness is also possible. The one thing you can remember, the hoarseness will be there, and that is due to which now? Recurrent laryngeal nerve, especially the left recurrent laryngeal nerves. And you can see the palsy, the injury, any or the pressing of the recurrent laryngeal nerves, any problem with the recurrent laryngeal nerves, there will be the hoarseness of the voice will be seen. Okay, so that you need to remember. So we have seen the episiotopic where the patient is under the loss of consciousness is there, and the patients they radiating to the back and the groin regions. So what we have seen that we see there is a thickening of the wall of the abdominal aorta. So we having seen that this is condition, we call this is the abdominal aortic aneurysms, and the sudden pain is there. So the patients in the shock, pulsatile. So what we will see that is the rupture of abdominal aortic aneurysms. After that, the parents of the 2-year-old boy applied to a clinic complaining of the right testicle abscess in the scrotum of the boy. Now we see there is absence of the testicles is there, and the testicles is miniaturized. Miniaturized means there is like the testicles are the small. It palp along the inguinal canal, but it palpitates along the inguinal canals. Hence our problem is solved, but it could not be moved down to the scrotum. What is the most probable diagnosis? So we call this condition as the cryptorchidism. Okay, we know that about the testis. If we talk about the testis, normally what it will present? It is present at the retroperitoneal region during the intrauterine life. During the intrauterine life, the retroperitoneal regions during the intrauterine life. Then after it will reach to the scrotums. Then will after it reach to scrotum after birth. It reached to the scrotum after the birth. But if the testis arrested in this pathway, if testis arrested in this pathway, in between this pathway, we call this as the undescendant testis. We call this as the undescendant testis will be called. Okay, we call this as the undescendant testis. Okay, let me write it here. We call this as the undescendant testis. Okay, if this testis it is following the normal path, then it come to the scrotum, means that is the normal testis. But वो अपना अगर रास्ता भटक जाए, जैसे तुम कभी कभी क्या करते हो, अपना रास्ता भटक जाते हो, इधर चला मैं उधर चला, जाने किधर मैं किधर चला, ठीक है, तो उसके चक्कर में क्या होगा, if this testis will deviate from their normal path, so we call this as the ectopic testis. We call that is the ectopic testis. So we having the undescendant testis. What we call the undescendant testis, that another name is cryptorchidisms. That is the cryptorchidisms, that is the answer. Okay, and remember that the cryptorchidisms, it is the most common congenital anomaly in male genitalia. Most common congenital anomaly in male genitalia of male genitalia. Okay, we can having the ectopic testis, and the ectopic testis deviate from the normal path of the descent. Deviate from the normal path of descent. Deviate from the normal path of descent. We call it as the ectopic testis. We called it as the ectopic testis. What is the most common site of the undescendant testis? The most common site of undescendant testis. The most common site, remember, that is the inguinal canal. The most common site is the inguinal canal is the most common site. Okay, for the ectopic, remember the most common site is superficial inguinal pouch, but remember just the ectopic testis. If someone wants to write it, that is the ectopic test site, the most common site is the superficial inguinal pouch, after that femoral rings, then perineum, the root of the penis, all these can be there. Then it has some complications. Then it having the some complications can be seen in the undescendant testis. And what are these complications? These complications includes the complications we see, that is the A testis. What do you see? A testis. The A testis is what? That is the complications we will see. A for what we will see, that we will see there is atrophy of these testes. Because in the scrotum we have the more space, but in the inguinal canal we have the less space, so this testis will be atrophied. Then T4, this testis can go under the trauma because present in the inguinal canal, and after that it can lead to the epididymoorchitis. Epididymoorchitis. The inflammation of these testes can be the possibles. Then as for there can be the sterility. There can be the sterility is also possible, and the sterility here will be the bilateral. The sterility here will be the bilateral. Then T4 we see there is a torsion, testicular torsions can be seen. Ovarian torsion नहीं होगा क्योंकि ये क्या है, testis है. No one will say the ovarian torsion. And we can see the inguinal hernia. So inguinal hernia, that is the most common, and as means we can having these patients can lead to the seminoma. These patients can lead to the seminoma. I'm repeating it again. The atrophy is there, then after that atrophy there will the trauma will be there, and after the trauma epididymoorchitis will be there, the sterility will be there, the torsions will be there, the inguinal hernia will be there, and seminoma will be there. Is that okay? Everything clear? Okay, is that clear? Who is leaving the class? Don't know. Okay, so what we having? That is the right testicles. So we have the right testicles pseudo crypt. अरे क्या था? Crypt. अरे रुक जा भाई. So we will be having that right-sided cryptorchidisms, that is the inguinal forms. So inguinal forms, why the inguinal form? Because it is palpated along the inguinal canal. So that's why the inguinal forms. Okay. After that, this is the easy question that you can do. I know that somebody asked in the Croc 2 discussion group also. So what is the answer? That is the esophageal cancers. And I don't know what they was like the messaging something about. They're not focusing on the main thing. They're focusing something on different things. Okay, here you can see the firstly the weight loss will be there, and the weight loss, and after that you see that bad passing of the solid and the liquid food. Okay, if weight loss is there, the most probably in the Croc 2 question the answer will be the cancer itself. If you see the sudden arising crampy pain, so what will be the answer? That is, and what is the and if you see the pyloectasis, what is the pyloectasis? Pyloectasis means that there will be something like an accumulation of something. What accumulations? You see the loin. What is the firstly? Tell me what is the loin area? The loin area, like it is the portion of the like the body or the abdominal portions below the rib cage and just above the pelvis. Below rib cage and above the pelvis. Below rib cage and above pelvis. So we call this as the loin area. Above pelvis. So pain had started. Hematuria is also there. No pathological shadow ultrasounds, pyloectasis. So ectasis we know that is something accumulation. So here we will see the pyloectasis, there is an accumulation of urine due to some obstruction, due to some obstructions. So pyloectasis means something obstructing that thing. So obstruction means that can be the stone here. The left part is normal. That's why we will be having the stone of the right kidney, and we will see the kidney stone will be there. This we done already. Then we see the intense pain in the epigastrium is there, and we see there is a patient in the forced position bending on the right side with the leg obstructed stomach, the abdomen acute tenderness in the epigastriums, the guarding contraction of the observed. What is the preliminary diagnosis? So that is the perforation of the ulcers. We discussed that what in the peptic ulcers we have the complications, the post-hemorrhagic anemia, the perforation of the ulcers, and the perforation ulcers. Remember there will the guarding. Guarding means like some tenderness will be there. Guarding means some tenderness will be there. And patients will be in the forced positions, will be the bending forward on the right side with the leg obstructed to stomach. This is because the patient is in the pains, and that will help them to relieve the pain. The next question will be there, that the same question, acute thrombophlebitis. So we can see that the pain is there, hyperemia is there along the subcutaneous vein, the rise in body temperature, large in subcutaneous vein, the hyperemia, pain by pressing. Homans and Lucis symptoms are negative. What are the Homans and the Lucis signs seen in the DVT? Seen in the DVT. So what we call this condition, that is the acute thrombophlebitis of which vein? That is along the subcutaneous vein. So that's why we will be having the acute thrombophlebitis of the subcutaneous nerve. Now this question they not ask you directly what is the there is a not a topic. This is not a topic, acute thrombophlebitis of the subcutaneous. There is a topic we call the acute thrombophlebitis. It can be a topic. It can be a topic, this topic, not ectopic, not topic. So that can be a topic from this subject. But and DVT can also be a topic. So we need to rule out the other options in these type of the questions, or we have to we have to answer the questions according to the whatever the given in the questions. Like here we have the pain, hyperemia, subcutaneous veins, rise in the body temperatures, hormones and the leukocyte active, means DVT is not possible. Means DVT is not there. Okay. After that, lymphostasis. The lymphostasis, of course, definitely there is a no lymph formation is there. Acute iliofemoral phlebotomy. Did they mention about the iliofemoral? ना तो क्यों गाएंगे? ऐसा ही, ऐवी क्यों भाई? ऐसा नहीं है. Embolism of aorta not possible. The embolism of aorta we will see that if we having some like emboli formations or the IV, and in IV we know that there is a there are also not the IV also IV also here. After that, thrombosis of aorta, so no clot and nothing is there. So just there is a question is saying pain, hyperemia along the subcutaneous veins. Okay, so it means there is some inflammation, and inflammation we called it as the thrombophlebitis. After that, if you have the traffic accident, first what you will do? A, B, C, D, E. But here in this question, remember, there is a wide leather belt on the man's waist. So first we need to comfort the patient. If the patient is not comfort, then there is no need of giving the I, B, C, D, E. The first things we will comfort the patients. We will try to do, and what we do, we release this from the belt. So that's why conduct an artificial and closed chest cardiac massage after having released from the belt. After, okay, first you'll comfort, and then we can, because that will more work. If you will having some man waist and the wide leather belt is there, so that can prevent some type of the artificial ventilations. I think there is a both option is there in the question. Yeah, start immediate artificial ventilation of the chest and closed chest cardiac massage. So if this will be the option A, this will be the option B, definitely you will mark this on. Okay, and you will come with the silly mistakes. So don't do these mistakes in the exam. Read all the options carefully, whatever the option is there, according to your time management. An emergency team delivered a 83-year-old patient is complaining of the inability of the right leg to support the body after falling on a right side. Objectively, the patient lies on a gurney. Her right leg is rotated outwards. As the question is solved, if the right leg is rotated outward, we see in this case of the femoral neck fracture. The outside edge of the foot touches the bed. This is the positive state signs. This is again the not a specific sign, but as it is, what is the provisional diagnosis? So that's why they ask you the provisional. Provisional means not permanent. Gurney. What is the gurney? Gurney is wheels. Let me search it. Gurney is means that is the wheel. Yeah, that is the wheel stretchers. I forgot. That is the wheel stretcher. The wheel stretchers. Her right leg is rotated outwards. See, if the patient is there, if the patient like this patient is there, okay, if this patient is there and you see that this leg is there and leg is like this, what do we call this patient? The head is completely like this. So it means that this leg has been fractured, and the fracture sites will be mainly the fractures, because from here this limb will be short also. Short limb will be there, and this leg is rotated outwards. So we call this condition as the fracture of the necks. Let's see fracture of the neck. The fracture of neck. If we talk the fracture of the neck, so in which we see the leg will be shortened. The leg will be shortened and externally rotated. Externally rotated. The leg will be shortened and externally rotated. Along with that, what we will see there is a painful. We see there is a painful movement of hip joint. You will see there is a painful movement of hip joint will be there. The painful movement of the hip joint will be there. Along with that, what we will see there is a shortening, or like the legs will be shortened out, and there will be the, we can say, the externally rotated of which limbs? That is the things. Leg shortened and external rotation of the normal limbs or affected limbs. There is the affected limbs, because they can give you the both in the options, normal limb also or the affected limb also. The lesser, if you have the femur bone, and the femur bones, what we will be having? In the femur bones we will be having the lesser trochanterus and we will be having the greater trochanterus. So the lesser trochanterus will be more prominent. Lesser trochanter will be more prominent. The lesser trochanter will be more prominent. Okay, so remember these things about the fracture of the necks. If you see any fractures having the legs, if you see the legs shortened and externally rotated outwards, so that means the outward edge of the foot touches the bed. Normally, can you do the outward edge of the touches can touch the beds? It will be very, very hard to touch. Okay, but if he will able to, if he is able to do like this, it means that is something fracture. And which fracture is there? The fracture of the neck will be there. After that, a 50-year-old patient complained of the bursting pains. Okay, let's take a 5 minutes break and then we will continue, or take a 10 minutes break. ठीक है? भैया लोइन एंड ग्रोइन आर डिफरेंट. यस, लोइन जो होता है ना, सिंपली अगर बोलूं मैं, लोइन जो है वो कंप्लीटली लाइक देखो, रिब केस से और पेल्विस के तक पार्ट जो है वो क्या हो गया, वो तो हो गया लोइन. और जो ग्रोइन जो पार्ट है, ग्रोइन मतलब दैट इज द एरिया ऑफ द बॉडी, मतलब वो एरिया जहाँ पे अपर थाई मीट्स द लाइक द पेरिनियल एरिया. द पेरिनियल एरिया यू कैन से दैट इज द ग्रोइन रीजन्स. ठीक है, द जेनिटेलियर रीजन बेसिकली दैट इज द ग्रोइन रीजन्स. Okay, let's take a 10 minutes break and then we will continue. Sit. No. Sit has been happened. Oh, I think we should not take a break because this happened. Can you see? And I think this will be biggest thing now. Sit, yaar. Oh, no, it's okay. Finally बच गया. Finally it's safe. Can you see? थैंक गॉड इट्स नॉट स्टक देयर। अगर ये वहीं पे स्टक हो जाती ना तब दिक्कत हो जाती, बट एक का नुकसान हो गया। किसी को ब्रेक नहीं लेना था तो वैसे बता देता कि वी डोंट वांट ब्रेक, ब्रेक नहीं देता। किसने लगाई, किसने नजर लगाई? ठीक है, कल से ब्रेक नहीं मिलेगा। ये तो पूरा टूट गया। चलो भाई दूसरी तोड़ते हैं। कुछ नहीं भाई, तुम्हें क्या लग रहा है यूक्रेन वाला ही सी है पास? इंडिया में आओ तब पता चलेगा। नॉट ओनली यूक्रेन। यार पहले मेरे को एक बार इसको देखने तो चल रहा है भाई। अरे भाई कुछ ना कुछ तो दिक्कत आएगी पक्का। पेन कहाँ गया यार? Oh, thank God it's working. शुक्र है काम कर रहा है। काउंसलिंग के अपडेट नहीं आया यार कुछ भी। नो अपडेट ऑफ काउंसलिंग टिल नाउ। can start. Yes, you can start. I am listening. I am listening. You can start. So today Mr. Ji will teach us and we will listen. Okay. So let's start from the question number 78. A 50-year-old patient complains of bursting pain in the left lower limb that is getting worse on exercise, swelling in the region of the shin and foot. Objectively, left shin and foot are duggy. The skin of the lower shin is indurated, has a bronze stain, subcutaneous veins are dilated. There is ulcer with the necrotic mass. So, yesterday we discussed the DVT topic, and in the DVT we discussed that if it is complicated, it can be lead to the venous ulcers, and finally, if it is completely venous ulcers will be there, then it will convert into the Morgagni ulcers, and after that, if it is continually complicated, then further it will lead to the this type of conditions. It will lead to the there is gangrenous or the necrosis formations will be there. The gangrenous or the necrosis type of the things will be there. We will see in this type of the things. Okay, in the same question here we also the bursting pain in the left lower limb that is getting worse on exercise. That is getting worse on exercise when we have exercise or when we are walking. Swelling in the region of the shin and foot. Left shin and foot are doggy. The skin of the lower shin is indurated and has a bronze-tilled subcutaneous veins are dilated. Ulcer with the necrotic masses. What is the most likely diagnosis? So we have seen the ulcer with the necrotic masses. What is the most likely diagnosis? So that's the post-thrombophlebitic syndromes. Okay. So these are the complications, or we can say the complications of the varicose veins also. The complications of the varicose veins. The complications of varicose vein. So it will be like venous ulcers, and after the venous ulcer, it is most commonly around the medial malleolus. It's always involved around the medial malleolus. That's the most common site around the medial malleolus. Around the medial malleolus. After that, we will see and. What are the we discussed the varicose vein clinical features we discussed, right? There is a aching pain in the calf muscles or the shin muscles or the heel. There is bleedings. Then further it will lead to the venous ulcer. After the venous ulcers, it can lead to the lipodermatosclerosis. It can lead to the lipodermatosclerosis. And after the lipodermatosclerosis, it can lead to the something necrosis or the gangrenous type of the things. Necrosis or the gangrenous type of the things. Okay, so we call this condition as the post-thrombophlebitic syndromes. The post-thrombophlebitic syndrome, it's occur due to long-term effects. It occur due to long-term effect. It occur due to long-term effects. Okay, this is the complications of that is the DVT. The complications of the DVT, that is the post-thrombophlebitic syndromes. Okay. Then the next questions we will be having that the periproctitis. The periproctitis we discussed about the rectums. So proctor means proctoscopy. We discussed the tell the name of the proctoscopy. So procto means rectum. So we are visualizing the rectum. So that is proctitis. The proctitis means inflammation of the rectums. Inflammation of the rectal or rectal sheath. Peri means around. The peri means will be that around. So around the rectal sheath, what we will see, there is inflammations. So that is the periproctitis. So 3 days ago, 29-year patient for the pulsating pain in the region of the rectum. There is a pulsating pain in the region of the rectum. Fever is there, then general weakness is there, local tenderness in the anal regions because of the inflammations, revealed a painful infiltration. The pain infiltrations like the pus-like formations that reaching the pectinate lines or going towards the rectal sheath. So we call this condition as the periproctitis or the especially mainly the proctitis. If it is surrounding the rectal sheath, so we call it the periproctitis. Other rectum conditions we discussed. Then we are having the next question about the senile cataract. The senile cataract, remember, when we have talked about the senile cataract, this is also known as the peripheral cataract. This is also known as the peripheral cataract. Peripheral cortical cataract. What you will see in this persons like the senile. Senile, देखो senile when we come the senile means सठिया जाना. Senile means सठिया जाना, the old age. हम बोल देते हैं ना सठिया गया, ठीक है, सठिया जाना. तो सठिया जाना मतलब that is the senile, that the old age means will there. So old age will be there, like here we see the 65-year-old. And 65 year the most common is the senile cataract. The means cataract that is related to the age things. So that we call the senile cataracts. What we will see, there is a loss of the vision in dim light. There is a loss of vision where in dim light at the night times. At night, we call this condition as the nyctalopia. We call this condition as the nyctalopia. Okay, so that is what, that is the senile cataract. Okay. ठीक है यहाँ तक. So senile cataract, that is the peripheral cortical cataract, and after that we will be having the loss of visions in the dim light, and we will be having the night times. We call this condition as the nyctalopia. Okay, what we will see in this case of the senile cataract, what the like pathology or the etiology we will see. So remember that if we talk about that, so what we will see, there is a lens is there, and if there is a the lens, if the watery lens will be there, that will cause the soft cataract. There will be the hydration of the lens. There will be the hydration of lens will be there. The earliest change that you will see, the earliest change will be seen the formation of water cleft. The earliest change will be seen that the formation of water cleft will be there. The formation of water clefts will be there, and vacuoles formations will be seen. The vacuoles formations will be seen, and it will lead to the lamellar separations. It will lead to the laminar separations will be there. There will the lamellar separation will be there. Okay, so that you need to remember, and it is common in the old age, more than 60, more than equal to 60-year-old. We see that the senile cataract. So here we can see the gradual worsening of the left eye vision. So remember, there will be the like as it is the age. So in the whenever the age things will come, so there in that things the gradual things will be done. The gradual worsening, not suddenly will be there. Everything will be occur gradually. So the left eye vision during the 10 months on physical examination, acuity of the vision of the left eye 0.01. The eye is quiet, pupils of eye is greyish. See, when the pupils will be the greyish colors, when this senile cataract will convert into the, this senile cataract is there, so this senile cataract will be having, as we have discussed, there will be the formation of the water clefts. After that the lamellar separations will be there. The eye lamellar, they will be separated out, and we will see there is a wedge shape opacity will be seen. We see there is a wedge shape opacity will be seen. If we see the wedge shape opacity, the wedge shape opacity, it is seen in the cuneiform cataract. The wedge shape opacity, it is seen in cuneiform cataract. This is seen in the cuneiform cataract, and the most commonly we see that is the wedge shaped opacity. The wedge shaped opacity will be seen. If this wedge shaped opacity further will be converted into the immature cataract, further will be converted into the immature cataract. And this immature cataract will be looks like the greyish whitish color. This will be looks like the greyish whitish color. Okay, so that we call that is the, that's why we call that the pain increase. So here we see the pupil of the eye is the greyish, the reflexes from the eye ground is absent, So we have the intraocular pressure is there. What is the most probable clinical diagnosis? So we will see the age and the gradual worsening is there, and that further it will lead to the these type of the things. So we call this condition as the senile cataract. We call this condition as the senile cataract. Okay. After that we will be having, okay, understand these things. If you see the like more age, more than 60 years, so that will be the most probably that will be the senile cataract. And you see there is some opacity will be there, the loss of visions will be there, so they all comes under the senile cataract. Then we will see that the 36-year-old patient was admitted to hospital with a sharp pain in the substernal area following the occasional swallowing of the fish bone. Now fish bone is here is what? That is the foreign body. That is the foreign body. The fish bone here is what? That is the foreign body. On esophagoscopy, the foreign body was not revealed. The pain increased and localized between the scapula. The pain increased and localized between the scapula. In a day temperature elevated, the condition become worse. The dysphagia intensified. So what complication has developed? Now see, we discussed the dysphagia, in which we discussed the eclasia cardia, we discussed about all these things. Then remember that if we talk about, this is again the like the problem or the associated with the chest pains. If any foreign body in the esophagus, if any foreign body in the esophagus, what we will see, this is most commonly, if you see any foreign body, where it will go? The most common, it is seen in the children. The most commonly, it is seen in the children. Let me write it here. The most commonly, it will seen in the most commonly, it will be seen in the children's. And in the children's, what we will see, the most, or which is the most common foreign body, the most common foreign body in children's, that is coin. That is the coin. In adults, that is the most common foreign body, it is the fish bone. It is the fish bone. In elder peoples, the most common foreign body, that will be the dentar or the loose teeth. The dentar or loose teeth will be there. Dentar or loose teeth will be there. What we will see, the symptoms. Symptoms we will see in this patient, the choking will be there. The patients will be choke. So the choking conditions will be there. Okay. Like if you it can be problem in any foreign body can be like stuck in the esophagus, like if food bolus can be the stuck in the esophagus, and if this food bolus get impacted in the esophagus, so at that times give the Fiji drinks. At that times give the Fiji drinks like Coca-Cola, soda, all these type of the drinks that can help to relieve them. But now our problem is that if this fish bone, if it is rupture the or perforate the esophagus, so it will cause the mediastinus type of the things. Now see, there will be, if we talk about the esophageal perforations, there will be the esophageal perforation. But foreign body is not the most common cause. The foreign body is not the most common cause. The most common cause of esophageal perforation is what? That the iatrogenic. That is the iatrogenic. Can you tell me what is the iatrogenic? What is iatrogenic? In glaucoma, the intraocular pressures will be more. In glaucoma, the intraocular pressures will be more. And I think glaucoma questions was there where I discussed that. What is mishaps done in hospital by the nurses or the medical coach? हाँ शायद मैंने बताया था, मेरे को याद है ये. So esophageal perforation, the most common cause is what? That the iatrogenic, and that will be like doctor induced or like any staff nurse can be there. So that is we call that is the iatrogenic. Any doctor induces things is there, that is the iatrogenic. Idiopathic means unknown conditions. Idiopathic means unknown conditions. Okay, other than the esophageal perforations, other after first is iatrogenic, and after that Bohr-Haave syndrome. After that the Bohr-Haave syndrome will be there. But if this foreign body, if it is rupturing the esophageal perforations, then it will lead to the some inflammatory type of the things, and that will help the problem in the dysphagia and the mediastinitis, as we discussed in the Bohr-Haave syndrome also. All these type of the mediastinitis will be formed. On esophagoscopy, the foreign body was not revealed. Oh my God! He took the fish, he swallowed the fish bone, but in the esophagus, foreign body was not revealed. The pain increased and localized between the scapula, means it is present in mediastinal regions. In a day temperature elevated, condition became worse, dysphagia intensified, means some foreign body is there, but foreign body is not in the esophagus, the foreign body is in the mediastinum. That's why it's in esophagus we are not able to see the foreign body. That's why we will answer the complication, the perforation of the esophagus with mediastinitis will be there. Okay. Okay, take care, bye, good night. Then question number 82. 82 is saying the hemophilia B. Hemophilia B. So hemophilia B, what the treatment we will give is that we will give the fresh frozen plasma. What we will give? The fresh frozen plasma. Oh my God, what is the fresh frozen plasma? The fresh frozen plasma is the richest source of the clotting factor. It is the rich source or the richest source of the clotting factors. So if any coagulation factor deficiency, if any, it used for multiple coagulation factor deficiency. Okay, that is the hemophilia. But if it is the case of the hemophilia A, it is the case of the hemophilia A or C. So A or C, remember, we will give the cryoprecipitate. So first we will give the cryoprecipitate more than the fresh frozen plasma. But if it is the case of the hemophilia B, then in that conditions what we will give is, we will give the fresh frozen plasma. What we will give? That will give the fresh frozen plasma. We will not give the plasma, we will give the plasma. And the plasma, remember, that is the richest source of the clotting factors, and it can be used for the multiple coagulation factors. Can you tell me which is the coagulation? Hemophilia A, B, C? Hemophilia A, hemophilia B, hemophilia C. Which clotting factors? Hemophilia A, B, C. Which coagulation factors will be there? Please bata do, bata do, bata do. 8, 9, 11. 8, 9, 11. 8, 9, 11. So the answer is 8, 9, 11. The answer is 8. It is not 8. It is 8. In Roman. Then 9. Then 11. Okay, the 8, 9 and 11 deficiency, that is the first, second and A, B or C. After that, the question number 83. On the 4th day after recovering from a cold, a patient was hospitalized with the complaint of the solitary spitting of the mucoid sputum. On the 2nd day, there was single discharge of purulent blood stick sputum. So what is C? The purulent blood stick sputum. Patient condition is moderately severe. Respiratory rate is 28. Pulse rate is this. AP is this. Respiration above the left lung, vesicular, weak above the right lung. They are the moist rail. So we have seen there is a respiration above the left lung is vesicular, weak above the right lung, the moist rail of the different kind above the lower lobe, and amphoric breath near the angle of scapula. What is the most likely diagnosis? So we have seen that there is a, we can see that the different type of the rails and the amphoric breath near the angle of scapula. It tells up the amphoric breath if it is there. So remember that if it is telling the amphoric breath, so amphoric breath means that is telling the, or it is characterizing that this patient can having undergo the consolidation, or we call this as the amphoric breath, or the we also call it as the cavernous breathing. it is the indication of the any cyst, like if there is any like cavity formations can be there, or some air containing space, or the like pneumothorax thing for the things. In that things we will see there will be the amphotic breath will be here. So what we will see other than that, if this type of the things air will be there, so the lung consolidations will be seen. Lung consolidations will be seen, and the lung consolidation here, as we'll see the question, so that is according to the which cavity or the abscess, so that is again the abscess. Why there is abscess formations will be there, that is a, we have seen that this patient is having firstly, if you're having the case of any acute pulmonary abscess, the onsets can be the gradual onset, or it can be the like the abrupt, like sudden onsets can be there. The patients will be having like the fever, sweating, cough, and chest pains will be there. Okay, if you see like here the main keyword is here that you need to remember, that the amphoric breath. If you see the amphoric breath is telling us that the cavernous breathing. It telling us that if any cyst or the cavity or air containing space is there, it means if any air containing space is there, we can assume that this patient is having some problem with the lung consolidations, and the patient is having cavity that is filled with the abscess, and that is giving the purulent blood stick sputums. Okay, that you need to remember. Other things we already discussed, the acute focal pneumonia. In the acute focal pneumonia, there is a single lobe or the single part will be affected. Then pneumothorax, the pus plus pneumonia, pneumothorax will be there. Pleural empyema, we discussed that there is abscess, and there is accumulation of the pus in the pleural cavity. Exudative pleuritis, there is a accumulation of the pus within the pleural space. Pleural empyema, that is the accumulation of the pus in pleural cavity. Okay, and plus there will be the inflammation also. There will be the inflammation also. This is done. We have the post-traumatic empyema of the earth. What will do the function of the drainage of the pleural cavity? That is the repeated questions. Then we have the question number 85. When it question number 85, remember there is a question about the peritonsillar abscess, and the peritonsillar abscess, remember that is quinsy. So that is what quinsy. That is quinsy. Quinsy, or we call it as the peritonsillar abscess. The peritonsillar abscess. What is these conditions? If we see there is a collection of pus, between the tonsils, collection of pus between tonsil and tonsillar beds, between the tonsil and tonsillar beds. So we call this condition as the quinsy. It is mostly unilateral condition. And what you will see, it is more common in adults. More common in the adults. Like if you see that, let's assume this is open mouth, and here we are seeing there is quinsy. So what it will do, it will press on the uvula. So there will be the prella, and what they will do, they will push the uvula on the other side. I will share the image after the class. The uvula will be pushed on other side. The more important feature that you need to remember, there will be no neck swelling. In the quinsy. If neck swelling is there, So remember, that is not the quinsy. That is the can be the paratonsillar abscess, that can the retroperitonsillar abscess, but it is not the peritonsillar abscess. Okay, what are the chief complaint or the clinical features we will see in this condition? The patients will be having the trismus. What is the trismus? Difficulty in the mouth opening. Difficulty in the mouth opening, and the trismus, it is due to medial pterygoid muscles. This is medial pterygoid muscles. This is due to medial pterygoid muscles. Then after the trismus, what you will see, that there will be the hot potato voice. Hot potato voice will be there. Hot potato voice, or we can say the plumby voice. So which kind of the voice will be there? Are you able to hear me? अरे तुम बताते भी नहीं हो, अच्छे से आवाज नहीं आ रही. आवाज आ रही है अच्छे से? या अभी अच्छे से आ रही है? इतनी दूर से माइक कैप्चर कर लेता है क्या आवाज? So what you have seen, the hot potato voice or the plummy voice. Hot potato voice and the plummy voice. Like this type of the sound will be there. Hot plummy voice and the plummy voice. So this type of the sounds you will hear, hot potato voice or the plummy voice, or we can say the soft voice, or we can say the muffled voice will be here. Okay. What you will do, there is a treatment, you will need to IND. What is the IND? The incision and drainage. What you will do? Incision and drainage, and remove the tonsil after 6 weeks. Removal of tonsils after 6 weeks. After 6 weeks. And this is called the interval tonsillectomy. This is called interval tonsillectomy. Okay. If it is the neck swelling, that is not the peritonsillar abscess, that you need to remember. After that, if you see that there will be the like the trismus is there, that difficulty in the mouth opening, and it is due to medial pterygoid muscles. Trismus is here is due to medial pterygoid muscles. Now we have seen that the intense pressing pain in the pharynx. The intense pressing pain in the pharynx, mainly to the right side. So this is a unilateral. Impossibility to swallow even the liquid food because of the like trismus is there, and the completely swelling inside that. The illness started 5 days ago. The patient condition, body temperature is -38, speech is difficult, hoarseness, that is the hot potato voice. Voice is constant, difficulty in opening the mouth, that is the trismus. Difficulty in the opening the mouth, that is the trismus. So submaxillary gland to the right are the painful, enlarged. Most probable diagnosis is what? That is the peritonsillar abscess, or we call this condition as the quinsy. We call quinsy. We call this condition as the quinsy. Okay, is that correct? Then after that, question number 86, you need to do it by yourselves. That is abdominal aortic aneurysms. Then after that, question number 87, I hope everyone write this. Okay, quinsy, that collection of pus between the tonsillar breast, unilateral conditions, uvula will pushed on the either sides, and the tonsils will be the medially pushed, and there is no neck swelling will be there. The trismus, hot potato voice, IND will be there. The interval tonsillectomy will be there. An hour after an elective surgery, a 56-year-old patient of surgical department got a dramatic increase in the blood pressures. There is a dramatic increase in the blood pressures, tachycardia, hand tremors. Then patient is confused and depressed, fearless, pessimistic about the operation outcome, refuses the surgery. What tactics should be chosen by the surgery? Now see, this patient come for the elective surgery. Elective surgery like an hour before an elective surgery, like if that is pre-planned surgery, and we call the elective. A 56-year-old patient is there, got a dramatic. What you have? The dramatic. It is not actual. So dramatic increase in the blood pressure. There is a tachycardia will be there. Hand tremor is there. The patient is confused, anxious, depressed, fearful, pessimistic about the operation outcomes कि क्या होगा, मैं मर तो नहीं जाऊंगा इतनी जवानी में, है ना? Refuses the surgery. Then what tactics would be chosen by a surgeons? So what you need to do? Wait, like this is like the like according to the rule, what we need to do, we have to, after the correction of the blood pressures, or once his sympathetic system has been down, then we will start the surgery. Of course we cannot do the surgery in such type of the patients, and we need to like consolidate that patients is everything is okay, you will not die so soon, you will have times, and everything will be perfect, you will be have more growth. Okay, like we need to consolidate the patients, predict the psychological state of the patients. Now, organize the monitoring of the patient by this family member. No, this is the normal things that we have to seen in the patients. Organize the monitor patient by the medical personnel and the mental health counselors. Don't waste time in such things. Isolate the patients. We have to wait. So because this is not like till kab tak kalega, because this is the dramatically increase and it will be not for a long time. So just wait, and once the correction has been done, start the surgery. After the patient with the suspicions of the pelvic bone fracture is under the examination conducted by the doctor, who presses the LI in the medial direction with his both hands, what cause painful syndrome of these patients? LI is what? That the iliac wings, that is the iliac wings, or we call it as the iliac crest. We call it as the iliac crest. We call it as the iliac crest. So what we have seen, there is pelvic bone fractures and the painful syndromes will be there. So what causes this painful syndromes? So we have seen that presses the iliac wings in the medial direction with his both hands, and so if we have these such type of the conditions, so this is what, that is the physical examination he is doing, that is the physical examinations. And this physical examination is done for assessing pelvic ring stability, for assessing the pelvic ring stability. If we see the pelvic ring disruption, if we see pelvic ring disruption, the pelvic disruption or any fracture, so it will be cause the pain. So this is what, that is the painful, causing the painful syndromes. So we have seen that when we doctor presses the iliac wings or the LI in the medial direction of both hands, when he is doing this physical examination, so the patients will be in the pain. So what is causing this patient? That is the disruption of the pelvic rings, because we know that the pelvic ring is like this, we having the one iliac wing here, one iliac wing here, and then we will be having, this will become the pubic symphysis. So that is what they become the pelvic ring. So if we put the pressures medially, that is the physical examinations to test whether the pelvic ring is stable or not. If there will be the pain will be there, so we will see there is a pelvic disruptions or the fractures can be there. So what is the cause of this painful syndrome? That is the disorder of continuity of the pelvic rings, or the disruption of the pelvic rings, or the fracture of the pelvic rings. Okay. A 30-year-old man injured in fire and got thermic burns of the third A and the third B degree that affected 20% of the total skins. AP 170/70, heart rate 120, but transfusion means should be used for the blind transfusion before the transportations. See, if we having some burn injury, like we have seen that this patient is having the burn injury. So if the burn injury patient is there, so in case of the burn injury patients, what we will see, we see there is a loss of proteins. And the fluids and the electrolytes will be there. Loss of protein, fluid, electrolyte will be there, and we will see that their patients will be undergo the hypovolemia. So if the patients will go under the hypovolemia, and shock will be there. As here we have the AP, that is the patient is under the process of the shock. There is a no much amount of the fluid loss is there. So that's why these patients will further, like if as it affecting the 20% of the total skin, so after that the patients will go under the shock. So in that patients, what we need to do, We need to resist that patients, and with the help of what we will give IV infusions. IV infusions, and to prevent the shocks. What IV infusions we will give? That we will provide the normal saline solutions to maintain the electrolyte imbalance. Normal saline solutions. And normal saline solution is what? That is 0.9% NaCl. That is 0.9% NaCl will be done. So what we will use Belaine before transportation? The saline solutions will be given. Okay, then after that, they leave these questions because big question. Okay, so let's do the questions tomorrow. I think today's study. So tomorrow, if you will able to finish the around 130 to 140 questions, then to 180, then 200. Yes, we will be finished this week. Okay. So revise this. Now it's good. What it is good? Voice is good. Okay. ठीक है. So revise these things again perfectly, and as I'm seeing that many of you are disconnecting the class. Maybe some of they disconnected because of Eid and all those things, but it's okay for them. But those who are not celebrating, you should be having the class and don't miss any class now, because this time you will think कि यार मेरे को पढ़ना भी है, class भी लेनी है, बहुत सारी चीजें हैं ना, that you will do, but just keep taking the class and everything will be good. Okay, whenever you will be in the, I had one, just a second, wait करो. Okay, so whenever you will